Hi there, and welcome back to this week's episode of the Delivered Podcast. I'm your host, Athena Estelle, and I am so glad that you've joined us this week. I am super excited to have a new guest this week. Her name is Dr. Jessica Vernon. She is joining us from New York City, and it was really cool because her PR director had reached out to me about showcasing her on my show. And I just thought that was the coolest thing, like a really cool connection. I love that. And she was super easy to talk to. So shout out to Courtney. Great job on doing your job. You do it very well. And Dr. Vernon is joining us from New York City. She is a perinatal specialist, and she's also the director at a really cool midwifery clinic named ULA. So welcome, Dr. Vernon. We're really glad that you're here.
Thank you so much. And please call me Jessica. I like to be like on the same wavelength as everyone. I'm so excited to be here, and I'm really not that fancy. I only have someone helping with PR because of my upcoming book launch, but normally it's just me.
I love it, though. I think it's fantastic. Give the listeners like your medical background. You know, where'd you go to med school? How did you find your passion in the OB world? And then we'll dive right into your book.
Yeah, perfect. So I am an OBGYN. I have been practicing in New York City for a decade now. I went to medical school at University of Texas in San Antonio. I actually spent my third and fourth years of medical school on the border of Mexico, and I got to work a lot with midwives down there because they are doing most of the obstetric care and the doctors are only doing the C-sections and operative vaginal births. So that's where I got my love for midwives. And then I did my residency in Baltimore and came to New York thereafter, and I've been here ever since. And I've really loved it. My focus shifted towards perinatal mental health about 5 years ago after my own experience with postpartum anxiety, depression, and OCD after my first daughter was born.
Okay. Do you want to give us a little background, just how your own experience played into that?
Yeah, it was huge. I didn't even know that I was suffering from perinatal mental health conditions until my daughter was close to 2 years old. I thought I just had the hypervigilance of a new mom, and that just kept going and got worse. And I had a lot of OCD with intrusive thoughts, and eventually over time it progressed to depression because I just thought this was how life was going to be. And that all kind of came to my low point when the COVID epidemic started in New York City. We were on lockdown. We were having to still go into the hospital and try to hold space for other people who were very anxious and pregnant and still not knowing what happened if we brought COVID home to our own kids. And so I just really got run down and was still functioning and working, but not very well. It took a lot of energy and it was really hard to get through the days. And that's when I kind of diagnosed myself. I knew I'd had episodes of anxiety and depression in the past. So I went to my primary care and said, put me on Zoloft. And immediately I was able to kind of get a perspective and separate myself a little bit from what was going on and be like, oh, this has been going on the whole time. And that's when I started looking more into perinatal mental health. In training, we're only taught to look for people who are severely depressed or suicidal. And that's changing, but I trained a while ago. And so we weren't doing routine screeners. We weren't really talking about how mom was feeling and doing at visits when we saw them postpartum. So I really, even myself, had no clue of what I was going through, even with all of these resources. And so I made it my mission to get the knowledge to be able to talk to patients about it, diagnose them, and treat uncomplicated patients who really can be treated through their OBGYN or primary care provider and don't need to wait to see a psychiatrist. And now I only see the more complicated patients with bipolar or very severe depression or other history that makes them higher risk where they really need that specialist. And I take care of the patients myself who can get care through a primary care provider.
I do think it's tough in the medical world because, you know, I'm a PT, so it's very different for me, but still you have the hoops of insurance and your provider and the referral and all these other things. And so I think if you can kind of cut out that whole piece and just treat those patients before they need a psychiatrist. I mean, that would have saved me months. I'll just be honest, So
Right.
I think that's fantastic what you're doing.
Thank you. Yeah, it's so hard. And even in a place like New York City, where we do have lots of psychiatrists and psychiatric nurse practitioners, a lot of them are not comfortable treating people in pregnancy and postpartum, or they're really not sure how to do it. So I've had patients come, for instance, who've been bipolar and said, my psychiatrist just told me to stop all my medications when I got pregnant, which is the worst thing you can tell a bipolar patient. So you have to be careful even when referring and making sure you're referring to someone who does have the knowledge and comfort in treating these patients. So it's, and you're right, for those who do go to the psychiatrist, often it's 2-3 months wait. Often they think they take their insurance and then they get a call before the appointment that their insurance coverage changed and they no longer accept their insurance. So there are so many hoops people have to jump through just to get in with a psychiatrist often.
Yeah, that's very cool. Now, go ahead. Tell us about your book. I'm very excited about this. So how did you get to the point where you actually put the pen on the paper or like the key clicks on the computer? Because I feel like I've always had so many ideas. That's kind of why this podcast exists. I always joked that I'd write a book. I'm obviously not there yet. But how did you actually take that step? I mean, other than physically like typing with your fingers, you know what I'm saying? What was the push that you were like, okay, it's time. I'm doing this.
Right. It was a long process after I recovered from my own postpartum anxiety and depression and OCD. I started increasing awareness on it and talking to my colleagues, talking to a little bit in the media, definitely talking to my patients. And as I was talking to people about these issues and asking them questions about how their own experience went, and my patients started really opening up to me, I realized there were so many of the same themes that were coming up over and over in parts of their experience that had led them to really feel guilty or like failures or all alone or like something was wrong with them. And so I knew this was something that I was covering one-on-one with patients, but that it would be great to get that information out to people in general so that more people knew what they could expect and how things might go off course from what they expected. And so it is a book that came out of that. It came out of my own journey and out of my patients' experiences that I kept hearing over and over. And it's really a book written for the person giving birth. It's not about your baby. It's not about how to optimize yourself to have a healthy pregnancy or recover postpartum. It's really about the parts of birth and postpartum and this transition to parenthood that is really very pivotal and complex in our lives. And all of the things that you might not have expected or that might surprise you that they could happen to you or you never even heard about, so that people feel a little more prepared and hopefully don't feel as bad if they happen to them and don't suffer from as much birth trauma when something goes off course. So that's really where it came out of. And it's been a very long process. I started it 3 to 4 years ago, and I only put my book proposal together right before my second daughter was born. That was my deadline. I was like, I want to submit this to agents before the baby's born because who knows what's going to happen after that. And now she's 2.5. So it's been that whole time since I got the agent and the publisher and wrote the book.
That's awesome. Now tell us the name and the release day, how they can get it, all of that good information.
Yeah. So the book is called Then Comes Baby, an honest conversation about birth, postpartum, and the complex transition to parenthood. It is being released this May. So Mother's Day, Mental Health Awareness Month. It's perfect timing for all of that. You can get it now at any of your major booksellers through the publisher, Rowman & Littlefield, Amazon. You can look at your local booksellers as well if you want to support independent booksellers. But yeah, it's available everywhere now.
That's so exciting. I love that it's coming out in May. I think May has become my favorite month, just between Mother's Day, obviously being a mom, and just coming out of everything and being, I don't know, I always say I feel like alive again, which always sounds so cliche, but when you're in the pit, that's all you can think about. You can't even, there is no forward thought. At least for me, there wasn't. It was just like, I'm stuck here in this like pit, And so now it's such an exciting month. I love that it's also maternal mental health month. It's such an important thing. And I feel like the more you talk about it, the more you find the people that were in the same cycle that you were in, that you realize you're not alone. Because the newborn phase, it's isolating in general. And then, you said you have a 5-year-old, right?
She's now 6, and I started working in this area around 5 years ago. Yeah.
Okay, so it was almost COVID, right? You were right before that.
Yes.
So then, you have all the first-time moms that had children during one of the craziest times in modern history. So it's wild, but I think that's awesome. I will definitely have the link to the book. I love that it's coming out in May. I'm super excited about that. And congratulations. That's a huge victory.
Thank you so much. There's still a lot of imposter syndrome about writing a book. It's hard to put that in as part of my identity, but I hope it helps some people. And that's really why I did it.
Oh, absolutely. I'm sure it will. And just knowing that not only did you live it, but you're also a physician who's trained in that field. I mean, you are the bread and butter. You know what I'm saying? You are the root. Like, the facts, everything. I think that's huge. I mean, who better to take advice from?
Yeah, but there was so much I didn't know, which was so surprising to me. How much, not just about mental health, but about the postpartum recovery process and everything that happens. And after I went through it myself, I just kind of thought back about seeing all of these people who'd given birth in the office, and you're really just asking them, like, how's the baby? How are you doing? You can have sex again. You can work out again. Do you want birth control? And I've like, after this is terrible how we're doing this one visit, very little time spent with patients. And that's why I kind of changed my whole practice and how I was asking questions and what questions I was asking. And it took me going through it and just being shocked with my own experience to get there. So it was more, even as someone who was an expert in this field, there was so much I didn't know. And even with all the resources I have at my disposal as someone who's a physician in New York City, there was just still so many things that took me a while to get to and access and navigate on my own. So I can't imagine for people who are in resource poor settings, people from marginalized communities, people who just don't have any of this access and their providers aren't talking about it. There's so many people struggling on their own. It's just, we say the rates are 1 in 5 to 1 in 7 of postpartum depression, but I'm sure they're much higher. We just aren't capturing everybody.
It's ironic that you say that, because I've always wondered, like, the people that, like you said, in those different areas, or the people without access to a computer or a library or these resources, that we're very fortunate for sure. Yeah. And I think it's great that you sought out that knowledge and used your platform for, obviously, the betterment of society. You're living your medical code. I think that's great.
Thank you. Well, new parents have it hard enough. We need to do anything we can to help support them and meet them in a non-judgmental, safe space where they can open up about their experience and feel that they will be accepted and that they're not alone, and validate their experiences. All of that is so important, especially in a society where we're kind of in silos. We're in our little nuclear families, often far away from any extended families, or a community of people who have given birth and are surrounding you after you've given birth. So there's really not a lot of good ways for people to prepare for this.
Yeah. And what you said struck a chord with me when you said, we're always asking about the baby. How's the baby? What's the baby doing? How's the baby eating? Blah, blah, blah. And, before I ever had a child, those were my questions. And now that I've been through what I've been through, now I'm the friend that's asking, but what are your thoughts like? Are you eating? How are you sleeping? What, all these truly important questions that you just don't think to ask because you're so hyper focused on, obviously, this beautiful new life. But at the same time, if the giver of life isn't at a healthy level, you can't maintain that for very long safely.
Right. And that's something that I always try to impress upon people who have given birth recently is that you are the most important person, the most important influence on your baby. And so taking care of yourself is not just necessary for you so you can be a whole person and be healthy and happy, but it's also the most important thing for your baby, more important than exclusive breastfeeding, more important than any of these things that were sold in our materialistic society to help us be good moms and take care of our babies. And so I really try to get people to focus, like, your sleep is very important for your baby. And you taking time off and getting help from family, friends, babysitters, whatever it is, so that you can fill up yourself in ways that are important to you, that is of utmost importance to your baby as well.
Absolutely. Now, earlier you mentioned the transition into motherhood, and there's a really cool medical word for that called matrescence, which I've butchered so many times, but now I fully understand how to say it. But in your opinion, give us like how you explain matrescence to your patients, and then how can we, as a postpartum community, normalize this process that we kind of just said the focus has always been on baby, but also now you're taking a woman through this life-changing process. You know, how are you helping your patients navigate that?
Sure. So matrescence, I talk about it the same way you would talk about puberty. It is a huge transitional time in a person's life, and it involves all of the physical, mental, emotional changes that you're going through. When we go through puberty, everyone knows, like, teenagers are going through a lot. Parents reach out and support each other. They talk about how they're caring for their teenagers and what's going on and how wild that time is, and how their brain is just changing so rapidly. They're not functioning the same as they used to. They're not the same person they used to be. The same thing is happening to people when they give birth. And I think there's an even more rapid and acute change. And at the pivotal aspect of it, when your hormones are changing, your brain is changing, your body has just given birth, you're also responsible for a new little human being, this life that needs you 24/7, while you yourself are going through so much physically and in your brain and hormonally, and all of the emotions that come along with having a new identity and mourning your old identity, even though you might love and are embracing your new identity. There's just so much going on, and we tend to ignore it and not acknowledge it. And so it makes it really hard for people to talk about this, or even having a name to put to it can be helpful, because people often think, like, what is going on? Am I losing my mind? My brain feels so funny. I'm crying about everything. I'm yelling at my partner. I do love my baby, but I also want to run away and scream and hide. And I miss going out with my friends and having autonomy. And so letting people know this is all okay and a normal part of the process can be really helpful and validating, and lets people know this is a lot. It's a lot for anyone to go through. And though people have babies every day, there's so many babies born, it's very common. It doesn't mean it's easy. And so I think we really need to create more spaces for people to talk about their experience, and also let their support systems know what's going on with them, so that they can help them through this process and really ask them how they're feeling and how they can help, and make sure that they're there to support the person who gave birth as well.
One of my prior guests, I believe it was one of my motherhood coach friends, she said that she recommended to a client that they make like a to-do list of things that they themselves wanted to get done, and they put it on the fridge. And I guess when people would come and visit for the baby, everybody asks, like, what can you do? What can you do? And most moms, like everybody, we're all like, nothing, we're fine. But on the inside, you're dying for someone to run your vacuum. So she would just tell them, there's a list on the fridge if you want to do something before you leave. And she said it was great. Like her to-do list was like, check, 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 check. So I think that's a great idea. I also think having a postpartum, either like a therapy consult with a therapist if you've seen one prior, or finding a new one, or having something set like that just in case as a safety net, I think that can be pivotal, because you can only talk to your support person or your spouse or your partner for so long about things, right? I feel like you always need that third party that's objective. What you're feeling is valid. This is very normal, you know? So it's like you said, just because it's happening, thousands of times a day doesn't mean that it's easy. It's still one of the biggest transitions of your life.
Right. Right. It is. I think arguably it is one of the most pivotal transitions in a person's life for the person giving birth and their partner as well. And we don't talk about the partners that much, but they also need support and preparation for this transition. And when I see people for mental health consults before they give birth, often people who have risk factors or they already are having anxiety or depression, I definitely recommend that they start seeing a therapist during pregnancy, because once you're postpartum, it is so hard to line up that support. And just like getting a good psychiatrist, finding a therapist can take a while. Finding one who you really click with can take a while, and someone who specializes in this area. And also either have your partner come in on some sessions with a therapist or have a separate couples therapist to talk about some anticipatory guidance for how things are going to look when the baby comes, how you're going to communicate, what ways you can help the person who's given birth. Because so many people, just like you said, postpartum are just frustrated and resentful that their partner and the other people in their life are not helping out, but they haven't asked for help. And I know we shouldn't always have to ask for help, but often people need guidance on the ways they can support the person who's given birth. There's also lots of places that have great support groups, and Postpartum Support International has free weekly support groups, and they have tons of different groups. So I encourage everyone to go on there, because having a community that can validate your feelings and also talk about how they kind of set boundaries, said no to people, asked for help, all of those things can be really wonderful, because as women in society, we're trained to be the martyr and to be selfless and do everything ourselves. And so a lot of people who are giving birth often feel like, yeah, I could ask for help, but I can do everything myself, and I should do everything myself because I'm the mom and it should just be natural and easy. Or I do this better than my partner does it. They're floundering around. It takes them longer. I can get the baby down quicker. And so I tell them, you have to encourage and allow the other people who are your support system to do these things. And if that means you go in the other room and you put in earplugs and white noise so you can't hear how long the baby's crying, you do it, because your partner has to be able to do these things as well. It can't just be you all of the time. And the earlier you start this and make it an equal partnership, the better it is in the long term.
That's so true. I'm so awful at being like, well, I can do that faster, so I'm just going to do it. And then it defeats the purpose. So yes, ask for help. Seek the help. It's crucial.
Right.
Now, you are a medical director at a really cool clinic called ULA in the city, and it is a midwifery clinic. So first, I just want you to explain to the listeners, what is the difference between a midwife and an OB? Obviously, the large things will come to the OB, but just kind of explain the difference. And then I want you to tell us about ULA and just how the holistic training and systems there are different compared to like a typical OB practice.
Sure, absolutely. So midwives are also fully board certified practitioners. And you do have to be careful, because there are lay midwives who are not board certified in their specialty. They may do home births in some areas. And so you really have to, if you're looking for a midwife, know what their training is, if they have privileges at a hospital as well, because only board certified midwives can get privileges at a hospital to do deliveries there. So midwives are the experts in physiologic birth. And what I mean by that is uncomplicated birth, people going into labor on their own. I hate to use the word natural, because people feel bad if they have to be induced or they have a birth that has an epidural, but they are really the experts in the spontaneous birth process, letting people progress on their own, supporting them with interventions that don't involve pain medication if they're trying to have a birth that's unmedicated, and a vaginal birth process. The midwives also do full prenatal care. They do postpartum care. They can do gynecologic care as well. So some midwives don't, but a lot of midwives will also see you for your annual GYN visit and basic GYN concerns. And so they are a fully functioning provider. They do not have to have an OB overseeing them. A lot of them work in collaboration with OBs, like we do at my practice. It's a collaborative care practice. And the OBs are experts in more complicated births. So anyone who requires a C-section, the obstetrician performs the C-section. Anyone who needs what's called an operative vaginal birth with forceps or vacuum delivery to expedite the delivery vaginally, that is done by obstetricians as well. And often if there's complications that come up in pregnancy, if you're seeing a midwife, they will refer you to an obstetrician or an even more specialized person called a maternal fetal medicine specialist who only deals with high-risk pregnancies to consult or co-manage during the pregnancy. And then if anything comes up during labor and birth that is higher risk than within the midwife skill set, then they will escalate and bring the obstetrician in. And so it's always important that you are aligned with your provider and you understand, if you are seeing a midwife, what happens if I need to be transferred to an OB? Are you working collaboratively with OBs? If you're trying to have a home birth, which some people are, I've worked in academic hospitals where the midwife doesn't have privileges at the hospital. And so a patient will just come in after being in labor at home for days and nothing's happening. And so they're coming into an environment where they don't know the obstetricians. They're just partnered with whoever is covering for the hospital. And then they're in this brand new environment with a provider they've never met. So it's always good if you're working with a midwife to know whether it's home birth, birth center, hospital birth, how they're partnering with OBs and high-risk specialists if your care needs to be escalated. But really, midwives are amazing at providing uncomplicated, low-risk birth and caring for you during the pregnancy and postpartum as well. And they do it in an incredibly holistic way. They're often asking a lot of questions that obstetricians, when they're running around very quickly seeing a patient every 10 to 15 minutes, are not taking the time to delve into. So midwives tend to take more time and really get into those aspects of care. So a lot of people really like having the midwife care.
I really like that. So this might be getting into the weeds, but I'm just wondering, so midwives, you said that they're licensed, they're board certified, right?
Yes.
Okay. So do they have to have an OB to practice? If a midwife is following a patient and then say that patient goes into birth and goes into labor, say that patient goes into labor. Okay. And they, come to the clinic, they come to your clinic, they're ready to go. They're, getting ready to deliver. Is there an OB there as well in case something does go south? Or is that midwife like an independent practitioner?
Yeah, that's a great question. They are independent practitioners. And so for instance, if you are doing a home birth with a certified midwife who has been privileged, credentialed, or you're doing a birth center birth and things need to transfer to the hospital, then if the midwife is credentialed, then they may have hospital privileges as well, but not all of them do get hospital privileges. So some of them will call 911 and have an ambulance bring the birthing person to the hospital. If you are at a practice like ULA where I work, we have OBs that work for ULA. And so we always have midwives covering labor and delivery. We do not do home births or birth center births. We only have births in the hospital, and we partner with one hospital in the city. And so there are always midwives covering labor and delivery, and there's always an ULA obstetrician on labor and delivery as well. So we can easily escalate care. Sometimes the midwife and the OB are there for the delivery. Even if we have C-sections, our midwives are sitting at the bedside with the birthing person and their partner while the obstetrician is performing the surgery. So they're providing another layer of support for the patient, even if it's a surgical birth. But you definitely have to really parse it out and talk to the midwives you're interviewing and see where do they do deliveries, what happens if you need an obstetrician, how that works out, because you want to make sure you're aware of everything. And this is another aspect where some people might be extremely low risk and they think, I would never need to go to the hospital to give birth. I'm going to be having a home birth with my lay midwife and everything will go totally fine. I'm low risk. I'm not going to need a C-section. And I've seen some of those people get transferred to the hospital, and it's really traumatic because they never anticipated it or expected it. And then they're at the hospital with a provider like myself who is just meeting them and sometimes saying, you've been in labor for 3 days, your baby's heart rate doesn't look good, we need to go have a cesarean birth. And when that was not even on your radar, it can be really hard to process.
I've always wondered how traumatic that can be. I had a friend that I grew up with in grade school, home birth, planned, all the things. And then she ended up in the hospital, same thing, a hospital emergency C-section. And I just think that has to be a whole other level of like birth trauma because, you know, it wasn't on your radar. You didn't expect it at all. And then bam. And then I'm a chicken. I love my house so much and the memories here and obviously all those wonderful things. But it terrifies me to think about having a child here just because I think maybe because I'm medical minded. So I'm like, well, where's the monitor? Where's this? Where like, I need to see the wavelength and all these things. But I love that there's another layer with having the midwife present and the way that your practice handles that. I think that's just another layer of consistency of care, continuum of care. And I think that that's really important, especially in such a large transition in life.
Totally. It is. And sometimes you're going to have a midwife or an obstetrician that you haven't met before. And that happens in most practices now because none of us can work 24/7. And so there's very few solo practitioners these days. Most people either share call coverage or in a practice where you're rotating who's in the hospital and who's in the office. And so you may or may not have met the provider or providers that are involved in your labor and birth process. But knowing how your practice is set up in advance can be really helpful. And also going to a place where they do provide holistic care and very person-centered care. Even something that could have been traumatic in other situations might not be traumatic. And we know that trauma is in the eyes of the beholder. So two people can go through the same exact situation and experience it very differently. And so I have had patients who came to the midwives for an unmedicated vaginal birth, end up developing preeclampsia later in pregnancy, having to be induced, and after days of induction, end up needing a cesarean section. And if everything was explained to them and they were able to have conversations along the way, they were involved in all of the decisions, even though it might be a disappointment, it definitely wasn't what they desired. They're able to be flexible and feel like they were still supported and safe throughout the process and might not have trauma. On the other side, there are people I've seen who I've witnessed, they've had a beautiful and medicated birth just as they wanted. And afterwards, they're like, that was the worst experience of my life. I felt so vulnerable. I felt so exposed. I pooped on myself. You know, all of these things are, we kind of are like, oh, okay. So it's not always the experience. It's how that person is experiencing it in their body.
I love that you said that. I've obviously thought of that before, but just the way that you explain that, it makes total sense. Now, when you have the moms, you know, they've given birth, they're going home, they're transitioning to postpartum life. When you're following up with them on the postpartum side of things, are there certain unspoken mental health challenges that you're seeing in these patients that I don't want to say are being swept under the rug, but maybe they're not noticing tendencies that they're having and you're picking up on them?
There's so much about it that often goes unseen and undiagnosed. And often it's because people aren't asking the questions, or even if they are asking the questions. For instance, a lot of providers now routinely implement the Edinburgh postpartum depression screener or the PHQ-9 sometimes does still do that as well. And the American College of OBGYNs is to routinely implement it now, at least once in pregnancy or in postpartum period. Patients often will lie on the screener because they either feel that there's going to be stigma, they're going to be deemed a bad parent, or often, especially marginalized communities like Black and brown moms, they have a higher risk of CPS being called in general. And so they're afraid if they write that they're struggling mentally, that somebody's going to call CPS and take away their child. And that's a real fear. There's also the sense that, yeah, I can tell you that I feel this way, but what are you going to do about it? Because often they're just given a list of providers to reach out to or told, call your insurance and find someone to see. And so it's really not doing them any benefit. And so a lot of how I'm able to elicit these concerns and get people to feel comfortable talking about it is, in our practice, we talk about it from the very first visit, the intake. We talk about people's baseline mental health. We talk about if they've had infertility or loss in the past or a history of obstetric trauma. These are all risk factors for them having anxiety and depression during and after pregnancy. There's so many other risk factors, but just broaching this from the beginning and letting them know, start thinking about support during pregnancy and after birth now. That alone just takes away some of the stigma and shame around it. And then routinely checking in with people throughout pregnancy. We at our practice do the screener in the first trimester, as well as around 24 to 28 weeks as well, to get a baseline. But our midwives are always asking, and our OBs are always asking every time they see the patient how they are doing mentally and emotionally as well. So that's a very commonplace topic. It also helps when you work in a place that has resources for people who are struggling with mental health. It's another way to normalize it. When I was at an academic hospital before I built out a collaborative care program, we had a reproductive psychiatry fellow in the office a couple times a week. We had a perinatal therapist in the office. I myself and a couple colleagues would provide care for uncomplicated people with anxiety and depression. And so if you're talking to people about their risks and their symptoms and their struggles, you can say, well, we can help take care of you right here. It's kind of like, this is so common and it's okay that you're feeling this way, that we've built support systems right in front of you to take care of this. And we're doing the same thing at ULA now. I'm providing care for low-risk patients. We have a lot of support people in our office as well. We don't have our own therapists yet, but in the future we will. And so these things are very helpful. We also have vetted resources, take insurances as well, not just ones who are out of pocket, which a lot of therapists and psychiatrists are, but vetted resources where we know they do perinatal care. We know they take our patients. We know our patients like them. And so we help connect and we keep following up with them until we make sure they've connected with those resources. So I think a lot of it is just normalizing mental health as a part of your pregnancy and postpartum care and talking about it and having providers feel comfortable talking about it. Because if your providers aren't comfortable talking about it, they often avoid the subject completely.
Very, very true. So for the underserved communities, what are ways, just as a mental health professional like yourself, how can you in that community increase not only access to it, but I guess helping those patients find the resources that they need? I know you kind of mentioned some of that, just having it available as an option.
Yeah.
But is there any other ways that they're able to access those resources?
Yeah, so there are some services. Postpartum Support International has a psychiatry consult line. And so if a provider sees a patient and they're not comfortable making a management plan, they can call and consult a psychiatrist who will give them recommendations so they can get the patient started in treatment before they're able to connect with a psychiatrist. There's also programs like the Massachusetts Child Psychiatry Access Program, or MCPAP, for moms. And they have a free hotline in Massachusetts, and they've expanded through some government funding and grants into other states where primary care providers can call and do the same thing, access a psychiatrist to make recommendations to start treatment. So that is great. Another thing is providers themselves can do the Postpartum Support International training in perinatal mental health, which I did, and they have an advanced pharmacotherapy course to help make you more comfortable and knowing what questions to ask before initiating medications and how to initiate medications yourself, and knowing which patients you really need to escalate to a psychiatrist so we can get more providers trained. There are also a lot of virtual services now, so patients can access someone with a specialty, like Luna Joy is one of them that only does perinatal mental health. And they're in a lot of states now. So people can virtually access a provider who might be in a different state, but is licensed in their state as well for virtual care. And that can be really helpful. But no matter where you are, you always can access things like the support groups on Postpartum Support International, the Maternal Mental Health Hotline, which is also staffed by PSI volunteers, but funded through HRSA, that you can talk to a counselor free up to 30 minutes a day. And so if you're really like, I need to talk to someone today, I haven't established with a therapist yet, or I'm just having a bad day, you can call them. They're not mental health providers in the sense that they're not prescribers or therapists, but they are counselors, and that has shown peer support is really helpful as well for people with mild to moderate symptoms. Of course, you know, a lot of people need other layers like therapy, medication, additional support resources. And so we want to make sure people are getting those who have them. But there are ways that we're starting to see the system change. A lot of grassroots efforts from people with lived experience who are building out ways for people to get access who live in these lower resource settings. And you want to know that any of these services that I've mentioned, they are not going to call CPS. They are not going to call emergency services on you. Obviously, if someone is suicidal or homicidal or has delusions or hallucinations, those are medical emergencies. If you're worried about postpartum psychosis or suicide or infanticide, you have to alert emergency services. But other than that, no one in these services is going to try to get your kids taken away or try to have you admitted to a hospital against your will.
That's very good to know. I think it's very scary making that first phone call, asking for help, trusting people with your story. It's all lots of different layers of scary. So I appreciate that you shared that. I think that's really important just to remember that, you know, the goal is to find healing. The goal is not to take away your child and your ability to be a mother. It's to help you find the resources to equip you to be the best mother that you can.
Right, right. I mean, we know in our society there is not a lot of support for new parents. And you can see its effect on people's mental health and emotional well-being. Often they're having to go back to work within a couple weeks of having the baby. There's no feeding support in the office. There's no childcare support from the state or government level. And so people are really struggling to hold it together, and they barely even can think about taking care of themselves. So we really need to continue to have these conversations and think about other ways where we can support parents, you know, in general, so they can get their basic needs met, their family's basic needs met, and then take care of themselves.
Absolutely. Yeah. Well, we've covered the gamut. I'm impressed. We did well. But is there anything that, you know, just in your experience, your expertise, your personal experience, anything that we didn't touch on that you want to share?
I just want people to know that whatever you are feeling during pregnancy, postpartum, I promise you, other people have felt that before. Other people have been there. And no matter what struggles you're having, it will get better. Accessing the right support, asking for help, whether it's a trusted friend or a medical provider, or just calling the maternal mental health hotline, whatever you do, just ask, and there are people who are there to support you and help you and get you through this. Because when you're in the middle of anything hard, when you have an infant at home or you're pregnant, it may seem like it's never going to end or change, but it does get better. I can promise you. Both of us here have been there. We're on the other side now. And so just find your village, get the support you need. Know that whatever you're feeling, you're not alone.
Yeah, definitely valid. I 100% agree with you, because I think it's isolating having a newborn at home in general. And then you feel like you're alone with like this cloud of emotions. But then you're right. The more you have these conversations, it's like, oh, I felt that. I felt that. It's just like the trickle effect. So I agree with you. Really, really important. Now I have to finish with my favorite question. What? I don't know why I love this, but I love it so much. So in your experience, if you could choose one word to describe either your practice at ULA or just your personal practice in the perimental health space, If you could choose one word to kind of encompass that, which I know is a lot, what would you say that word is?
I would say warm.
Explain.
I try to make a warm, welcoming environment. Like you will be safe, you will be held here. We're all human, right? And connecting with people on a human level, it just creates this like warmth and this energy that's like we're all here doing it together.
Okay, I will tell you, the minute you said warm, I got full body chills. I'm not kidding. Like it's a beautiful word, and I think I definitely didn't feel safe. I felt like I could have ran off the tracks at any minute. So I think that is very cool. And no one has said that yet in the last year and a half. I'm obsessed with that answer. Very nice, Dr. Jessica. I love it. Okay. And then last thing, I will post the link for the book and for ULA. But is there any other way if clients have questions about the book, or, if local people in New York City want to reach out for an appointment, what resource would you kind of point them toward?
Yeah, I mean, to get an appointment with me or through ULA, definitely go through the ULA website. If you want more information from myself, I have a website, Dr. Jessica Vernon. I also am on Instagram as Dr. Jessica Vernon. And like I mentioned earlier on, you can pre-order the book at any of your major booksellers now. But I've had people DM me before or reach out through LinkedIn or whatever, and I will respond. I'm not always quick because I do have boundaries with social media and I do not get on them very often. But I promise when I see your message, I will respond.
Okay. Well, thank you so much for your time. This has been wonderful. You are a great resource, and I'm just so thankful for your time.
Thank you. And thank you so much for putting out this podcast. It's really wonderful. And I'm so happy that so many people are talking about this and bringing awareness to this really pivotal time in a person's life.
Yes, definitely. And thank you for saying that. You're very sweet. I'm so glad you were here.
Thanks.
Thank you for joining us. We'll see you next week.